With Tara Costin at the Southern California Liver Centers. We also run the SHARP Liver Center, which is also part of the joint UCSD SHARP transplant program. So we also take care of a lot of transplant programs, and kind of a unique position I'm in this year because I'm actually going out to the community, finding these transplant patients at hospitals like SHARP Chula Vista, and then work them up for transplant and get them on the list. So it's one really interesting part about that, to kind of digress for a second, is the most common thing I find when I have these patients that first come to me is that they've already been told that they can't get transplanted. So there's a lot of misconceptions out there about liver disease, and so it's fun being in the community. I also still work for University of Texas and do telemedicine for them, so I'm keeping busy. And the title of my talk is A Hitchhiker's Guide to Hepatitis C Therapy. Is anybody a potential treater of hepatitis C, or what kind of folks do we have in the audience today? So we've got one treater back there. And then are anybody interested in just knowing more about the treatment, or where the questions lie today? Anybody want to reveal why they're interested in liver disease to me or anything like that? Yes?
I'm interested because I have had family members who have had it, and I avoided saying that they had it, and as a result passed away.
Yeah.
So that left me kind of...
So there is definitely some social stigma with hepatitis B in Asian communities. But there may also be some stigma with Hep C in other communities. It turns out, I'm just going to take a wild guess that maybe you're Latina, there is up to 3 times higher risk of HCV infection in Latino communities. So we'll talk a little bit more about that. So what does hepatitis mean? Hepatitis is inflammation of the liver, right? So it's an itis of the liver, and you can get it from viral hepatitis like B or C, but you can also get it from alcohol, fatty liver, some of the other things that we're going to talk about today. The liver is sort of the central area of metabolism for the body. When you ingest something, the food, the drug, the toxin, whatever it is, it goes into your small intestine. It's absorbed into the blood, and the first place it goes is into the portal vein, which then goes to the liver. So the liver detoxifies those things and metabolizes it, which is why it's complicated sometimes to use medicines in patients who have cirrhosis of the liver, because they have impaired metabolism of drugs and toxins often. So that's one of the main issues with advanced liver disease. Hep C, most people will get it from a blood-blood issue. That's usually IV drugs, tattoos. Anybody ever seen these 3 dots right here on somebody's hand? Mm-hmm. Anybody know what that means, stands for?
Mm-hmm. Some kind of gang thing.
It's a gang thing, yeah. Yeah, there she goes. Let me see your hand. You have it?
La vida loca.
You have it. Mi vida loca, right? So yeah, so it's the 3 little dots means mi vida loca. Sometimes you'll see MVL in that same spot. To me, that's a sign of some sort of homemade tattoo, usually. Usually they don't go to a shop to get that one. And usually what I say to people is, that I see this all the time, I'll see the little tattoo and I'll say, you got that in the basement of your friend's house with your boyfriend and his cousin did it. It's always some cousin guy, for some reason. It's like the guy with ink and he knows how to get the tats. So, that same population, mi vida loca, living the crazy life, they probably also dabbled with IV drugs. So there's a lot of overlap in people who use IV drugs and tattoos, but there's also this whole other cadre of patients who have no known risk factor for hepatitis C. And the patients I see that often are like my little cute Hispanic females, maybe 65 years old, and they just happen to get picked up once they have cirrhosis. Oh, maybe they had a child in Tijuana, maybe they got dental work in the 80s someplace, or a transfusion that they didn't know about even. So there's this whole other group of patients for which no known risk factor is identified, and they have very discrete risk factors. Sex is possible route of transmission as well. It's unusual to happen amongst monogamous heterosexual couples. So what you can see is a couple where, say, one partner has Hep C and the other one doesn't, and they've been having sex for maybe 25 years. maybe it slows down at the end, but they're still having sex every once in a while, right? And then, but on the other hand, if it's another population, like men who have sex with men, and they have receptive anal sex, the risk can be much higher. So sex generally is not a risk factor in those traditional scenes, but in other areas, the risk increases dramatically. If a patient has Hep C, there's some risk there for advanced liver disease, including cirrhosis of the liver. In patients who have Hep C cirrhosis, there's a heightened risk of liver cancer, especially if they're alcoholics or diabetics, up to 20 times higher. But even just a Hep C patient who didn't know they had Hep C and wasn't drinking, is not diabetic, has quite a high risk for liver cancer. And we estimate it somewhere between 1 and 5% per year. Which means that if you have Hep C and you have cirrhosis, that you should be checked regularly for liver cancer. And what the National Society recommends right now is every 6 months, you should have an ultrasound. Okay. There's a blood test called alpha-fetoprotein. There's some debate on whether we should do that every 6 months, but if you want to be complete, you can do an ultrasound and an alpha-fetoprotein every 6 months. Finally, there's been a rumor, there's information out there that Hep C is incurable, that treatment is hard to tolerate, and now things have changed dramatically. It's highly curable with an all-oral regimen on a short duration. Somewhere between 8 and 24 weeks, virtually all patients will be cured. Okay? So, and side effects are similar to placebo. That means that I could give you the Hep C medicine, or I can give you a placebo, and you're going to complain to me just about the same. And everybody likes to complain a little bit, so you're going to hear, oh, I've been feeling more tired since I took my Hep C medicines, or whatever it is, stomach aches, headaches. But it's similar to what you'd see in a placebo-treated patient, I would say. So who is infected? Well, I gave you guys some hints earlier about this risk associated with IV drugs. We think somewhere around 5 million people are infected with hepatitis C. Most of the traditional information we've gotten from the Institute of Medicine on this excludes marginalized patients, like those in prison, homeless people, illegal immigrants. So the total number in the U.S. is probably closer to 5 million compared to that 3.9 million I'm showing you on this slide. And in comparison, Dr. Gish's talk was about hepatitis B. There's probably 1 million HBV-infected individuals in the United States, and about the same number of HIV-infected patients. So, major public health issue, right? And there's been this information for the last few years out there that if you're a primary care doc, if you're seeing patients in any primary care setting, you should be asking your baby boomer, those people born between 1945 and 1965, to get a one-time test. Everybody should have probably heard this by now. And then, of course, anytime everybody hears everything, information changes, right? So I don't have a really pretty graph of this yet because this data is coming out, it's emerging so quickly that people haven't really published all of the information on it yet. But now what we're seeing is, instead of that normal distribution that we had been observing up until about 2013, now we're seeing a camel hump. 2 different distributions of HCV infected. And right here is right around where I was born. We didn't do IV drugs, we didn't do tattoos. None of my friends knew about that. Now we have a second wave of young people. Average year of birth, 1989, which is shocking, right? Shocking. I mean, I really just can't believe that. High rates of new HCV infections. And in 2015, we estimated that 34,000 new infections occurred. Mostly in that group, 1989, around that area, and person who were using IV drugs. Shocking. So it's a second epidemic that we're seeing at the same time, which is completely blowing everybody's minds. Because 3 years ago, what we were saying is like, oh, it's going to be great. By 2030, there's going to be no people infected with hepatitis C. Because in that year, we almost treated 200,000 patients with Hep C. The following year, it slowed down a little bit. And the following year, it slowed down. And the following year, it slowed down. And now, 2017, we'll probably treat 100,000 patients. Meanwhile, there's 34,000 new patients. And that number is rising. So what we were expecting was 2030, HCV would be eliminated. Now we're looking at it, and if you do the math, actually, it's like maybe a 20% reduction in infections by that year, which is totally confusing, I think, to everybody. And a lot of people still haven't caught up with this, so people are still talking about elimination of hepatitis C in the US by 2030. It's not going to happen. Not with what's happening right now. Yeah, go ahead.
Is this specifically the opioid epidemic that we keep reading about?
This is directly related to the opioid epidemic. The most common place this initially was seen was in the Appalachian, but this is from the New York Department of Public Health, this data right here that I'm showing you. So what we're seeing is a nationwide movement of young people infected with hepatitis C because of opioid use and injection of drugs. And most kids are smart enough to know not to use the same needle as somebody else uses. So what it seems like is they all get around a table like you guys have, and then they put their drugs in the middle, and everybody has their own needle, and then they're going and pulling from the same well, and then somebody in the well is putting back a little bit of blood. And so from when I've encountered these patients, which I'm starting to have one, every week or two, a new HCV infection, a young person who's sort of been clean for like 6 weeks and they know they have Hep C and that kind of story. They're maybe checked into some kind of rehab facility. Do you have another comment back there? No? Okay. So it's very interesting and upsetting, actually. And so I'm calling this a camel hump now. There's a rapid rise in HCV infections, and so that when you look at the distribution of people, it's more spread out. The other concerning thing was, so this is sort of what I was talking about. You have these regions like here. This is sort of the Appalachian region where you have this high increase, greater than 100% new infections, even in California, high rates of new HCV infections among people who are using IV drugs. So hopefully this doesn't continue forever, but if it were to continue at the pace, next year we would see higher rates of HCV infection again and lower rates of people getting treated. And this is sort of my sentiment that I was expressing before. It's highly unlikely 2030 in the United States we would eradicate hepatitis C. Now there's other places like Iceland, who has like a really fancy HCV eradication. There's Mongolia is set to eradicate like in a few years potentially. So there's some places where healthcare is more isolated, more controllable, that they will eradicate it in their country. But in the U.S., we are not on target based on what the data we saw in 2015. So aside from age, the other thing to think about is ethnicity, all right? So what we know is HCV infection varies dramatically amongst folks from different ethnic groups. African American males, 1 in 7 might be infected in their 50s. Hispanics, I mentioned earlier that their rates of HCV infection may be triple. Some studies show 6 times higher. So that means that if you're looking at an age-appropriate group in the US, you might see a 2%, and then in the Hispanics, you might see 6%. But another sort of compounding problem of that is Hep C in Hispanics is known to progress more rapidly. That means that if they get Hep C infection in 1990, well, within 20 years they might already have cirrhosis, whereas it might take a Caucasian or an African American 30 or 40 years to get cirrhosis. And that is in part because of something that Lisa Richards will talk about a little bit, which is the fatty liver. So if you have fatty liver and you have Hep C, you're in big trouble. You're going down the path towards transplant much faster than somebody else. So interestingly enough, African Americans lack that gene that causes fatty liver, whereas Hispanics tend to have it 50% of the time. So that probably explains one of the big differences between Hispanics and African Americans. This is some of the data that we generated here in San Diego. Actually, Dr. Gish and then Chris Ramers, who you're going to hear from in a little bit, we all worked on a big project to screen for hepatitis C in San Diego. And what did we see? Well, we saw high rates of HCV infection in people in the birth cohort. And so that's this group right here. This is our birth cohort, 1945 to 1965. And let's see, whoops, oh no. Okay, is my pointer? Okay. The pointer is kind of hard to see. But essentially, this group, let's see the pink guys here. So this is the Caucasians, right? And then here's the African Americans in the birth cohort. Very high rates of HCV infection, right? And then, so what this is looking at is the total number of patients and where they lie. But so if you look then at the next birth cohort, which is the 1966 to 1991 group, you see Caucasians. There's a high number of Caucasians, but then you also have a high number of Hispanics. So the Hispanics in San Diego who are HCV infected tended to be younger compared to the African Americans. High rates of infection in the Native American population there too. So you can see right there, very high rates of the Native Americans. So our own demographics here reflect what we're seeing nationwide. So I know I mentioned the Appalachians earlier, but it's happening right here in San Diego. Younger people have HCV infection, which then makes us need to take a step back because the original recommendation was screen people in the birth cohort. But based on what we're seeing now, if we really want to eradicate HCV, we need to screen everybody. Can you just screen people who do IV drugs? What do you guys think? Can we just focus on the IV drugs?
No.
Why not?
Medicaid has.
Because nobody will admit to doing IV drugs, right? Or they don't remember, or they think the time that they did it, it was cool. It was totally cool. I've had this conversation with 100 people. Yeah, but that was 20 years ago, dude. It's fine, it was cool that time. And I'm like, yeah, but you could still get Hep C from doing it just one time with your boyfriend's cousin in the basement 20 years ago. That still counts. Doesn't not count just because it only happened once or whatever. So that's a big problem. And when you rely on physicians or nurse practitioners or physician assistants or nurses or whoever it is to ask these questions to patients, what happens is 50% of the time the patient will be missed. And it's a combination of sometimes it's an awkward conversation for the provider, and sometimes the patient just doesn't want to remember it or doesn't remember it how you think they would remember it. I would certainly remember using IV drugs. I would, even if it was just once. But lots of people seem to not be able to remember this fact. So probably the eventual recommendation based on what I'm seeing now will be universal screening for hepatitis C. Possibly a one-time lifetime test, but if they're younger or higher risk, you would probably screen them more often, right? And then this is another interesting fact that, we know that there's about 2% of the US population is probably HCV infected. And if we look at the average load for a provider who's doing primary care, they have about 2,000 patients, which means everybody should have about 40 Hep C patients in their practice, right? So that's enough for a person who's doing primary care to become a Hep C treatment expert, I think. They could treat 10 people a year for 4 years and they'll know how to do Hep C therapy fine. I'm a transplant hepatologist by training. I'm board certified in that, gastroenterology, internal medicine. I even have a certification in something called obesity medicine, okay? So I'm busy. And patients sometimes don't want to come find me. I can be far, I'm on the road, I can only see so many patients. So it makes sense for primary care providers to be able to treat these patients, especially if the patient that they want to send to me has to take a bus to another bus over the Coronado Bridge to my clinic and maybe walk 4 blocks to see me for me to provide the Hep C services that they need. So we need to be able to provide this in the community to people who need it so that the barrier isn't just to get to the subspecialist. So I'm a big believer in primary care as treating or people who are interested in treating. I do think it's helpful for them to maybe be able to plug into an expert. So for example, I mentioned that I still work for University of Texas. So I do a project basically where every Friday we talk on the phone and we start about 20 people on Hep C therapy at 5 different community health centers. These are all underfunded patients, and it literally takes me, a minute to go over the case with them so that the patient never has to come find a hepatologist to get plugged in. So I think this is important. I think that everybody should look at their patients, make sure we're screening, but they're not. So right now people are trying to figure out why. why aren't primary care docs interested in finding these 40 patients? Anybody want to throw something out why it's hard to do right now? What's the barrier? It's $1 million question. Everybody wants to know why. What do you think?
I'm actually trying, because my doctor alone won't pay attention to that or hemochromatosis or that. They just don't pay attention to it. So I'm with you on trying to figure out why primary care is.
Why is primary? Yeah.
Why
I mean,
are they so afraid of it? With asking about hepatitis or things like that.
Some people think it's because the workload's already high and that they don't want to get into another topic. Because, like when you're seeing maybe 20 patients in a half day, like if you start bringing things up like, how are your kids? You got a kid in college? Oh, now you're 5 minutes into the kid in college, right? So just think, okay, so now we're going to bring up Hep C, and did you do IV drugs in the basement with cousin fulanito or whatever, So I think that's a barrier. So what some people are thinking is, well, okay, if the primary care doctor doesn't want to do it, maybe the nurses should be doing it. Maybe a nurse who before checks the patient in the room does it almost like a vital sign. Oh, you've been screened for this. Okay, you're due for your Hep C screening. I'm not even telling your doctor because you're just going to get distracted with it. I'm just going to add it to your orders. So that's another way of approaching it. But if we really want to get to eradication at any time in the future, there's going to have to be some kind of concerted effort and a different approach to what we're doing now. Because even with the recommendation from the CDC, it's a moving target. Now we have all these younger people, and then there's still this other group that can't remember whether they did IV drugs or not. So we need everybody's help, and if anybody has thoughts about it, let me know. So what's the benefit of curing a hepatitis C patient? This is a big question because there's some Hep C patients out there who have virtually no liver disease. Have you guys heard of this, right? It's called F0. It means if you do a liver biopsy or if you do something that's non-invasive like something called FibroScan, which can judge the amount of scar tissue in the liver, you'll find that that's normal. It's 0. Some of us may have stage 1. I might be a stage 1. I don't know. I had 4 tacos last night, so I might have got up to stage 1. So what would be the benefit of curing those patients? Or what would be the benefit of curing somebody who already needs a liver transplant? Right? So those are some questions out there, and there's different ways of answering that question, right? There's question, for the patient themselves. That one patient, how will he feel after being cured? Will they have an improved outlook on themselves to know that they don't have that stigma associated with Hep C? Or will they feel stronger or better? Or will their liver start to heal such that they don't need a liver transplant? There's other people in the community. Now we're going to reduce the number of HCV infections in Appalachia or New York City or along the San Diego Tijuana border, right? Or maybe there's a societal benefit, like maybe we're going to have an improvement in quality of life years or reduction in the total amount of healthcare expenditures in the year 2030 related to viral hepatitis because we won't be paying for all these transplants. So those are some of the questions that are out there. And a lot of the data that we have about cure from hepatitis C and long-term outcomes is from something called the interferon era. So before we had these medicines that I'm going to start talking about a little bit called direct-acting antivirals, all we had was interferon. I know you know interferon, right? So we had the interferon era, and in the interferon era, it was some cure rates were as low as 5 to 10% in the hardest to treat patients. The side effects included death of treatment. So nobody was that excited about taking interferon. Luckily, by the time I started treating Hep C patients by myself, we were already having the first direct-acting antiviral being introduced. And that one was, there was 2 of them. One was telaprevir and one was boceprevir. Telaprevir had the very unfortunate side effect of causing severe anal pruritus. So we would spend lots of time talking to patients about their itchy rectums, which was an interesting conversation. And then different approaches to try to help with that. And one of the things that seemed to really help was having enough fat in the diet. And so there was little tricks like, oh, well, try linseed oil. That'll really cut down on your anal itching. you know? And, but interferon was still part of that, so it was really hard to treat those patients. But anyways, the survival information that we have on patients who are cured from hepatitis C mostly come from interferon, and what we saw was improvement in fibrosis especially. So if you had cirrhosis, about 60% of patients would regress and their liver would start to heal. And we also saw an improvement in mortality. And if you look at some of those studies where the mortality improvement was shown, most of the improvement was related to non-liver related causes. And one of the leading improvements in survival was related to reduction in harm from alcohol. So you used interferon on a patient and you cured them, and that was so hard on them, it was such a commitment that they were like, I don't want to have anything happen to my liver ever again. I'm not drinking, I'm changing my quality of life or my outlook of life. And I'll talk about that in a little bit, how important that is. But the idea here is we have patients who are at this very far end of the spectrum, maybe end-stage liver disease. Can we bring them back so that their liver disease isn't so decompensated and just be cirrhotic? Or if we have a patient who has cirrhosis, can we go back to having them be 1 or 2, or even go back to being all the way back healed? And I think what's the factors that are going to really affect that patient is age. So if I'm curing a 36-year-old patient who supposedly has cirrhosis, could they come back and heal compared to maybe a 75-year-old person? Could they heal? Well, I think the 36-year-old is going to have a better chance. But some of those questions are still out there right now because our experience with these new drugs hasn't been long enough. So we don't know, with the massive treatments that we're doing out there, will we have the same effect as we had in the interferon era, where people had to do this major change in their life. So even if you cure a patient from liver disease like hepatitis C, they will still have that ongoing risk for liver cancer. So if you cure a patient who you think has level 3 or level 4 cirrhosis, then ongoing every 6 months until they tell you, I don't care if I get liver cancer, they should be getting an ultrasound. And that's similar to mammographies, right? Women are supposed to get mammographies until some certain age where they decide, I don't want to get mammographies. The irony is that year, when they're more older, that they decide that they don't want to have a mammography anymore, that's their highest cumulative risk year for getting breast cancer. So it's hard to say when it's like okay to get cancer and not care about it. Personally, if I thought I had a few more years to live, I would always want to get screened. So this is what I was referring to earlier. People who were cured during that interferon era did better than people who were not cured. And the improvement in survival was related to all causes of survival, not just liver specific. So that's one of the mysteries about hepatitis C. If you have hep C, you're more likely to get attacked by a pack of wild dogs, lung cancer, hit by a car. Anything that you can die of, you're more likely to die of it. So that's one of the curious things, because some insurance companies are saying, oh, we'll only treat you if you're liver sick, but you're going to die of everything else more often. It's unclear why that is. I mean, you could get into that on an individual basis, and this is the other thing that I mentioned earlier. This is the idea that when you really engage a hepatitis C patient, like we did in the interferon era, that you can get a different response than if you were just to kind of cure the patient without them really being concerned about it. So there's 2 effects here. One's called the Hawthorne effect, and the other one's called the Epiphany effect. So the Hawthorne effect, I think, is sort of like, you're like, okay, I'm going to cure you, but I need you to stop drinking. I need to stop smoking. I want to get your diabetes together before I can do it, because we're going to do interferon, and you're going to get so sick, you could die, so we've got to have the best chance of curing. And so people would buy into that. If they wouldn't buy into it, then you didn't treat them. So actually, interferon patients were well selected, because we would say, that guy is way too squirrely to treat. We can't do it. He's not going to do it. Or you would take a risk on somebody, and then it would end up like, all these weird things would happen. They would get in a bicycle accident. They would be, all these crazy things, and you're like, how is all this happening to you? So So that was the benefit of the interferon era. And then I think there was also this other thing that arose, which is called the epiphany effect, which is, they went through all of that. They did that. They made the changes that they needed to do to interferon era. And then after that, they were like, my liver is a temple, and I'm not drinking, and I'm going to watch my health, and I'm going to take good care of myself. And so those two things appear to be absent, I think, from current DAA therapy, which is, people come in, they see me 1, 2, 3 times, and they're wanting why hasn't their Hep C therapy showed up? They're still drinking, say, 1 to 2 40s a night, or they're still testing positive for methamphetamines, or whatever it is, that they haven't done these things. So the question is, am I going to help them really by curing their hepatitis C? Because hepatitis C related mortality of the liver will probably decrease, but that all-cause part, it doesn't improve. And especially the main thing, which is the alcohol. So in my thinking about this has changed too. So I'll admit, in 2013 and 14, I was thinking, it doesn't matter, everybody should just be treated because it's better to just have 1 liver disease instead of 2. And as I've seen this data emerge, now I'm thinking, well, I need to set up some kind of parameters with my patients. I need them to make some changes so that I can have this kind of Hawthorne effect with them, and that when they're cured, it's more of like, I did it, I succeeded, I beat the virus, rather than, I took, I had H. pylori and I took some medicines and my stomach feels a little better kind of thing. You want them to be like, wow, I did this. Mm-hmm. So I think that that's a challenge. And for example, my Texas treatment group, we were talking about this yesterday, because we always have these patients, they're drinking like a beer a night, or some of them are binge drinkers or whatever it is. And I said, I think what we should do is we institute an 8-week, you must be sober for 8 weeks. Tell them to do that. They come back in 8 weeks. And you have to kind of take their word for it, right? But if they say 8 weeks, I'm still drinking, okay, now we're going to give you some additional medicine to help you try to cut back on your alcohol. We're going to give you, set you to this program. We're going to do this. And then follow up with them in another 8 weeks. And then at that, I think, so at some point you have to decide, am I going to treat this patient or not? Because it may not be ethical to withhold treatment from a person who's drinking too, because, they still want to be treated. So we're not God, so we can't say, no, you can't have treatment because I don't like the way you're acting. So at some point, we have to decide, okay, no, the benefit is there for treatment. We tried, let's say these things to the patient. But I think some kind of process like that is really going to be important to see big benefit. Because like I said, we know interferon helped patients. We know it could kill you, but if you survived it, there is going to be a change, right? But now with DAAs, people aren't sure. Yeah.
I just, the interferon era, and I had a lot of people, because I work in the field of addiction and stuff. So,
Absolutely.
But there was a lot of depression that
Yes.
happened with interferon. It would make a lot of people that I knew in recovery from addiction or alcoholism, interferon and then get off the interferon because of depression. Did you see that?
I am in no way endorsing interferon use,
No.
because it was a horrible thing to put
But I
people
have friends
through.
that are, like you say, will not ever drink again because they went through interferon and will never, their liver is a temple. So
Interferon had horrible side effects, including severe depression that could lead to suicidality. It could just cause death itself from adverse drug reactions. It was a very complicated drug to use. When we used to use it, we had a 10-page consent form that the patient would have to sign. It's basically chemotherapy. We were putting on people a type of chemotherapy, and it was hard to handle, and sometimes it worked, and if it worked, then that patient would really be changed. If it didn't work, it could make people into worse depression and relapse on drugs or alcohol or give up. And Dr. Ramers is here, and he probably has seen people who have taken interferon and they had to be talked into taking the new medicine. So sometimes you really have to be like, no, the new medicines are good, like I promised, there's no side effects, and they're still very reluctant or very scared or unsure of whether they want to do it or not. So, I think I'm not saying we should go back to interferon by any means, but in a way, if we could treat the patients the way we did when we were doing interferon, just very careful, very aggressive at going for lifestyle changes, I think it would be a benefit there. But that's my opinion. There's still, more data that we need to know. Maybe that won't be the case. And so the other big question right now, and this question has mainly emerged from payers. And payers are like state Medicaids around the country, or these other Medicaid services like community health groups, and then even private payers like Blue Cross Blue Shield, is where should we pay for Hep C meds? Dr. Gish threw out a number, $90,000 for Hep C therapy. Initially, the price when we were buying one drug from Gilead and another drug from J&J was probably like $150,000. That was year one or stop one of HCV DAA therapy. And then when we saw the combination pills come out, the single tablets, the price dropped to probably $85,000. And then as each launch has happened, every time the iPhone comes out, it's more expensive, right? But with Hep C therapy, every time the new Hep C therapy comes down, they try to undercut the competition a little bit. So now we're seeing actually some pretty reasonable prices for state Medicaids, especially with Merck. So we're seeing a dramatic change in the HCV prescriptions and more availability with somewhat more underfunded payers. And the big question is, when is it worth it in this quality adjusted life year? Usually we put about $50,000. And the answer to that is essentially all stages of Hep C treatment. Stage 0, no liver damage at all, to 4 appear to be beneficial for quality of life adjusted years. There is a higher benefit of people who have more advanced liver disease compared to a lower benefit of people who have less advanced liver disease, but there's still a benefit across the board. And this is, one study that came out last year, but there's going to be more studies on this, and it's a moving target because the price is changing. So as the price gets lower, it becomes more valuable, right? So I think from all perspectives, what I'm seeing right now, there's benefit. Everybody should be cured, in my opinion. There's no person who shouldn't be cured. So how should we do it, is the next question. So I think HCV therapies can be pretty straightforward in most of our patients. To get to the diagnosis, you'll have to do step 1, which is screen for the HCV antibody. Essentially, all patients who have been exposed or are actively infected with hepatitis C should have a positive HCV antibody. And you can get this blood test done at Quest or LabCorp or your local lab company, whatever it is. And it's just a simple HCV ELISA. Where you just type in HCV antibody and you'll find that one. If you're a small clinic, and I've done this in a number of clinics around San Diego, there's a point of care test you can do, where you just do a single finger prick, like you're gonna do a blood sugar check, and you take a little wand over that drop of blood that comes, and you put it in a little solution, you dip it in, and then you put a little stick in there, and that stick will develop 2 lines if the patient's HCV infected. That's from OraSure or Quick. Ironically, they have a line that says C that turns positive every time, and that stands for control, not for hepatitis C. Nobody was thinking that through when they developed that test, but that does exist. So there's a point of care test you can do in your clinic, and I think the average cost for that point of care is $17. And for the most part, you can get that reimbursed as far as I know, and it takes about 20 minutes for it to be fully negative. But if it's positive pretty fast. So I think if you're seeing it not come back positive within the first minute or 2, it's probably going to be negative. So let's say you get a positive one of those. So what's the next step? You want to check the HCV viral load. And there's a test where you can do a reflex viral load to a genotype, and then even to resistance testing. So you don't have to send the patient constantly to the lab. You need to know the viral load is, if it's positive, it's positive. It's just like being pregnant, right? If it's 100,000 or if it's 10 million, it's positive. And patients always like to know, well, my viral load is 3 million, is that bad? Yes, it's bad, because it's positive, okay? It's bad until it's negative, and then it's good. If it's negative, it's good, okay? The genotype refers to the strain of hepatitis C that the patient has. And there's 6 different genotypes that are recognized currently, with subgenotypes amongst those 6 strains. And the most common in the United States, anybody want to take a wild guess? 1. Okay, and then there's a subtype, genotype 1A, which most people have. Anybody want to guess which animal probably started with Hep C and gave it to us? Monkeys? Why, do you have a monkey?
No.
You worried about that?
The cat.
Cow? Anybody else want to guess?
The cat.
Sometimes referred to as man's best friend.
Dog.
Dogs. So they think that hepatitis C came from a dog about 1,500 years ago, probably in Japan. And dogs carry a respiratory virus that unfortunately we didn't really discover until the last few years because it would have been very useful for HCV drug technology and development. But most likely the virus made the leap from man or from dog to human about 1,500 years ago. And then that guy who got Hep C went into the basement with his girlfriend's friend's cousin and did tattoos to everybody. And he did 6 people. He said, okay, I'm doing you 6, go out and have fun. And they all got on different boats and they spread around the world. And then they isolated geographically, okay? So that's why we see different geographic isolations of hepatitis C. It's because of that basement thing, okay? And then so, the guys who came on the boat over the United States mainly had the 1A infection. Japan, they kept their 1B infection. Egypt is famous for having 4 infection. India has a lot of 3. So you can see these big global pockets of hepatitis C, but then in smaller communities you can also see different pockets. So I have a group of patients, my Chechenias from Tecate, they're genotype 3A. And that's a bad one because genotype 3A does something intracellularly that affects diabetes. Some of the genotypes are associated with some things, like 3 is associated with diabetes, 1B with liver cancer. So they all also have their own little problems. So anyways, now you know your patient's genotype, let's say they're 1A, then you want to know how much liver damage they had. So you can do a liver biopsy. If you can't get a liver biopsy, you can try to do a FibroScan. FibroScan is like a little ultrasound 10 times, and it'll tell you, oh, stage 1, 2, 3, 4, whatever. You can send them to get an MRI. Rady's Children has a really fancy MRI that I use frequently. It'll stage them. You can do a blood test. You can order a fancy blood test called FibroSure, which costs $300. Or you can just look at their CMP and CBC and calculate their APRI score. So that's APRI. And you can Google that one. And you can estimate HCV damage with all those different mechanisms. I feel most safe with a patient who has like a really normal-looking APRI score if I'm not going to be able to get a FibroSure or a FibroScan or an MRI or liver biopsy. But as patients start to look sicker, you especially want to try to get more advanced testing for them because whatever you do not want to miss stage 3 or 4 because that person will have liver cancer in 5 years and come knock on your door and say, hey, why didn't we, I talked to Dr. Gutierrez and he said I should get an ultrasound every 6 months. What happened? We thought you were low. So you really want to push as far as you can. But in low resource settings, like my Texas patients, I do APRIs and I have to. That's all I can get. So you stage their fibrosis. And then now you want to also, you're doing a physical exam, you're checking in on the patient, what else is going on with them. You want to assess compliance. Are they a drinker? Are they actively using drugs? You're going to set up your own rules. You're going to say, oh, I'm not going to treat an IV drug user for a week or 6 weeks or 3 months or until they demonstrate this or that. Same with alcoholics. So that you're making up your own rules as you go along. There's something that's also called resistance testing, and that gives us an even closer look at, like, for example, our genotype 1A patients. And it's similar to the kind of resistance testing that Dr. Gish was describing, where the genetics of the virus is explored on a nucleotide level. And a single nucleotide change. So remember, our genes are composed of nucleotides, which is like ACGCTC, AGCTCC. It's just 4 letters that are repetitive, right? Which code for amino acids, right? Which is the same thing you get in your amino acid shake or whatever. Those are the building blocks of proteins, all right? So these viruses are just basically proteins. And a single nucleotide changes the way the virus protein is shaped. So it'll be shaped like that. It's like, hey, I'm over here, right? And then we designed the drug to fit with this, right? So it's like a lock and a key. And so that's what the direct-acting antivirals are. They're basically made us into molecular locksmiths, right? But if there's single nucleotide change there will result in a protein change, then it changes the way the protein's shaped, and then it's shaped like this. And then when the drug comes to bind at its spot, it's not there anymore. So that is the basic premise of resistance. And that's why it's so important to understand the HCV genome in your more complicated patients, because some of the drugs might not work as well. The effect, probably overall on a global level, is small, but amongst people who treat Hep C, this is of some interest. So I mentioned this word to you guys before, direct-acting antivirals, or DAA. These are the new HCV meds. They have a nice nomenclature so you don't get too confused. 3 different types that we're pretty much using right now. There's the protease inhibitors, they all end in Provir, NS5 inhibitors all end in Asvir, and the polymerase inhibitors end in Buvir. The most famous one is, of course, sofosbuvir, right? That was the one that gained notoriety on NPR and whatever as a $1,000 a day pill. Ideally, these are all oral regimens, right? With no interferon. They're interferon-free all oral regimens. And you want to use drugs from different classes that have non-overlapping mechanisms of action, right? So that you have good effects. So you have an effect here, an effect here, and an effect here. And that will reduce the risk that something that I mentioned earlier called resistance will matter, okay? And so that multi-drug strategy reduces the chance of failure and leads to high cure rates right now. You know, we're debating whether a 97 versus 98 versus 99 versus 100% cure rate makes a difference. That's what we want. And we started out with sort of the first round of drugs, which I mentioned, the anal itching drugs, telaprevir and boceprevir, right? And one of the weaknesses of those was that it was susceptible to something called resistance that we talked about, and the potency wasn't as good. But now we've seen sequential generations of these drugs. So now we're on even just next generation PIs that are going to be working in all the different strains where essentially resistance doesn't seem to be a major issue. The NS5A inhibitors, same thing. We're getting to the next level. So instead of having to worry about, oh, it's a genotype 1A patient and there's this resistant thing possible, now we're just going to be saying, look, it doesn't make a difference. These are pan-genotypic agents. Resistance isn't a major issue. So it's evolving quickly. My favorite HCV regimen was the one that we called Cosmos. That was the very first round that we had, and I just love the way it sounds. It's actually named after the study, and so we just call it Cosmos. But now we're getting a new HCV regimen practically every year, or 1 or 2. And you can see these are all the different options that you'd have if you're an HCV provider. So in some cases, some regimens are preferred by the payer, but that's probably okay because they're all highly effective. So you can just, you make sure that what they're offering me is going to work in my strain of hepatitis C. There's no serious drug-drug interactions, and it's safe for this patient's stage of liver disease. You can, work your way through this list pretty quickly. When you're deciding on how long to treat the patient, right now the main things you're going to want to keep track of is, had they been treated before? Were they treated with interferon before? Or were they one of the rare folks who failed already a direct-acting antiviral? You want to know if they have cirrhosis. If they have cirrhosis, how bad is their cirrhosis? And then you may be looking at these things like resistance that I've been talking about. And here's a cartoon. This is what maybe a 3D picture of a protein would look like. And then there's my key, which is the drug. So, we're working like molecular locksmiths to cure hepatitis C. So again, I think it's really important that these patients are thoroughly evaluated for cirrhosis or advanced fibrosis, which is level 3, because that's where the harm can happen in a patient who was treated but then not treated appropriately for their liver disease. So we need to keep a careful eye on the patient's liver disease that's underlying their infection. That may be also going to affect their duration, whether you want to use other medicines like ribavirin. So the drug-drug interactions are very important to review for some of the regimens. For example, you guys heard of Harboni? Everybody heard of Harboni, right? So Harboni's been very good about advertising on CNN. Anybody watch CNN? So it's like you're like brainwashed, you're already hearing all this stuff. Donald Trump's bad, Donald Trump's bad, Donald Trump's bad, and then they're like, oh, you need to get Humira, okay, and now I need to get Humira and Donald Trump's bad. Okay, now you need to go out on a boat and get your Hep C cured, because right? they have this guy rowing across, you know, a nice white guy on his boat out on this lake, and he's like, oh, I got Hep C.
Yeah.
I need to get it treated. Should I do that or should I keep it rolling my boat? Right. So that's what he's doing. And so then I go to these meetings with the companies, and what I've been asking them is, okay, so has that white guy gotten cured yet? Has he? Because what we know is there's 1 in 7 African American males in their 50s who are infected with hepatitis C. There's 3 times higher rates of HCV infection in Hispanics. And you guys haven't done any marketing towards those people. So every one of my 50-year-old white guys come in and ask me for Harboni because they've seen the commercial. They've seen it. And I've never, ever had a Hispanic patient come in and tell me, oh, I know about Harboni. I want Harboni. They don't. Like my Spanish-speaking patients, they don't see that commercial. So, and it's kind of interesting if you go and you look at Univision, they don't really have pharma companies advertising on them. And when they do, what they've seen is enormous uptick in use of new medications by Hispanics. So it's a tragedy that they're not marketing towards them, because the marketing campaign that Gilead's done, they've been spending something like $250 million a year on these marketing campaign. It's been very, very successful in this baby boomer population that's Caucasian. It's been incredible. And if you're an HCV provider, you know what I'm talking about. These guys come in and they know what they want. So, we need to keep evolving there. And I think hopefully, they're realizing they've treated those patients now. We've got these younger patients or these marginalized patients, and we need to get the word out there's a cure. So, as you're looking at folks who might be at risk for treatment failure, you're still going to want to treat your A1C, get it down a little bit. That's probably going to help with the cure rates. It may be a marker of noncompliance, so you want to try to get them to work on that. These medications, and really no new medications, give you a pregnancy safety risk assessment. We know from some of the HIV drugs that some of the HIV drugs were pretty safe, especially when using them for like hepatitis B, but C we don't really know yet. They don't give us that category warning anymore, so all the new drugs don't have a category warning. They do give you some information like, oh, we gave like a really high dose to these rats, and then some of the rats had like 2 heads, and some of them just had 1 head, and some don't. Oh, at this high dose, but it's impossible to know what that means in your patient. And so you want to also make sure that mental health issues are intact still, even if that risk for suicidality isn't there like it was with interferon. And like I said before, this is a list of FDA-approved regimens. You can see it's long, so there's a lot of options. The next wave are these medicines that are called pan-genotypic. That means medicines that you don't need to know whether they are 1A or 3 or 4 or whatever, because it's going to work pretty good or about the same in all of them. So you can see there's a lot of pan-genotypic options coming. So if you got your patient on treatment, in some cases, if you're a really resource-limited setting, you may not be checking labs all the time. If you're able to check labs, it's nice to check it 4 weeks to know that the viral load has gone undetectable, and that's probably a marker of compliance rather than efficacy of the drugs. In those scenarios, you might also be reviewing drug-drug interactions to make sure you didn't miss a drug-drug interaction, and then how is the patient feeling. And then you don't tell a patient they're cured until it's been 12 weeks since they've taken the medicines and their viral load's negative. And we call that sustained virologic response. It's a durable cure, which means that if I go out and I put them on high-dose steroids with infliximab and Remicade or cancer medicines, that Hep C is not coming back. And there's no reservoir of hepatitis C. When you're cured, you're cured. But you can get reinfected, right? So what they've seen in high-risk groups where they've cured, up to 25% of those patients might get reinfected. Men who have sex with men and prisoners especially seem to be high risk for recurrence of HCV. And I had one prisoner when I was in Texas that I cured, and then he like violated his parole or something like that, and then guess what he came back to me with? A tattoo, a prison tattoo, like a big one, like on his back. And I was like, are you crazy? And he was like an older guy too, he was like in his 50s, you know? I'm like, are you crazy? That you went and got a tattoo again after that's probably, you know, they share that needle, the ink that they use they get from rocks or something like that, or lipstick, I don't even know, they make their ink a crazy way. And then he went and did it again. So you would think that people wouldn't return to their risk factors, but even if their antibody's positive, they're not protected. It's not like Hep B, where Dr. Gish is like, oh, if they have a core antibody that's positive and a negative surface antibody, they're safe from Hep B. No, it's not the case, okay? They can get reinfected. So this is my algorithm. You guys can look at it, or if you're going to treat, you can follow it. If not, you can follow your own. You know, it incorporates some elements of using all the regimens, like if you have a patient who's using ribavirin, you might check a CDC a little bit more frequently. So what do you do if you don't have insurance or you out of luck? Interesting, the people who are well-funded and completely unfunded are actually the easiest people to treat. It's the people in the middle, right, who are underfunded. So if you have a patient with no insurance and they can get to a provider who will prescribe them and monitor them on therapy, they can get free drug. Most of the companies aren't giving free drug to patients who are on Medicaid. They're trying to squeeze the Medicaids to actually pay for the drug so that they can get the meds. Initially, all you had to do to get free drug for a lot of patients was prove that they were rejected a few times or one time or whatever it was. Now it's more complex. They have to be unfunded. But if they're unfunded and they can give you a social security number, etc., you can get them therapy. And we do it with a lot of patients, and it's not that hard. Okay? So this is information if your patient happens to have it for all those companies. Oops, this is kind of complicated. So this was something that was very famous for the HIV care continuum. And so now we're looking at like what's happening with these Hep C patients. So like I said, maybe there's 3 to 5 million people infected with hepatitis C. Maybe half of them know about it. Maybe only a third of that have had the infection confirmed. And then smaller numbers going down to like 10% when this graph was developed have been cured. You know, that number is changing because, like I said, we have these new HCV infections and then rates of treatment have changed. So most of the work is still ahead of us. That is the most important part of this slide, even if it's a crazy slide. Doesn't want to go away. Okay. And then this is another way of looking at our country. This is not people who voted for Donald Trump versus Hillary Clinton. This is states that will allow treatment on Medicaid or not, which is basically the same thing. And you can see places like Texas. There's a big... Everybody who voted for Donald Trump? Nobody wants to vote. I did. No, I didn't. You can see places like Texas, where I came from. You virtually have to be very sick to get your Hep C treatment paid for, all the way to level 3 scar tissue. And I've been telling you guys, if you let your patient get to level 3 scar tissue, they have to get checked for liver cancer every 6 months. So now you're saying, okay, no, I'm going to wait until you have this risk for liver cancer and need for a liver transplant before I'm going to cure you. And so this is what's happening around our country. And there's this thing that's on the horizon for us right now, a $1 trillion cut in funding for underfunded patients. And so this will get worse, not better. This is going to get worse next year. This is where, you know, if you have these Hep C patients, get them tested now, get them into treatment, because it's going to be even harder to treat them in 2018 and 2019 if these guys in Washington get what they want. So it does not look good, and that's one of the key challenges on the horizon, this $880 billion cut that we're faced with. probably the HCV medications were going to be part of this thing. You know, a lot of these patients are underfunded, and especially as the epidemic grows and younger underfunded patients, right? So, but it's not that complicated to cure patients, right? You screen them, you check their viral load and genotype, make sure that their liver disease is either mild or severe. Try to get them on a lifestyle plan where they can experience the Hawthorne and the Epiphany effect. You want to get the full bang for your buck. And then you're going to tailor that treatment to the patient. Drug-drug interactions are manageable, just need to be reviewed from time to time. And essentially, all the regimens have high cure rates. So, you know, a patient shouldn't be upset that their regimen isn't the one on TV, because essentially they're all going to get cured eventually. And access is the main challenge right now. Finding these patients, finding ways to get them diagnosed, finding ways to get them funded for treatment, getting them to come to places where they can get treatment. So I think all of those things, you know, this is something the ALF, I'm sure, has on their mind, and, you know, I have it on my mind, and hopefully today you guys will have it all on your mind, right? This is my contact in case anybody wants to email me. I didn't give my cell phone number out on this one because I'm worried that it might end up on the internet.